All right. So I thought we were going to get through all of the joints. Not. I don't want to rush through the last two topics when we get to joints. So we'll cover the knee thoroughly because it's really important. And then from that point on, we'll do what kind of the amount of arthritis stuff that I can get through. Of note, so effectively we are just now entering into the second half of the course. Because this is at the end of the 8th week, 15-week course, so 7.5, I think Wednesday maybe was the midpoint, somewhat officially. It gets a whole lot more difficult after this. This is structure and basic function. We have muscle physiology, nerve physiology, autonomic nervous system, all coming up. They are all hard. Parts of the brain, really the functionality of parts of the brain, which I know you did probably parts of the brain and all that stuff. Yeah, that's coming up. So it really is a lot to do. The one thing I will not do, because we will never have time for it, they always want us to, it's like the eye physiology and stuff like that. I'll leave it to the next one to do that. You don't want to have that now anymore. Not all that other stuff coming up for a final. So, the point I'm making is it really is, now that lab is absent, this is a much harder material. And again, because you don't have lab to contend with, it should afford you a certain larger amount of time to devote to this aspect, which is really where students always find this the most difficult part. To that end, if you did not know, and I double checked by contacting the people at that, whatever the resources for student services, for whatever the tutoring center, whatever that is, whatever they call that acronym. But nevertheless, I'll get together the email and forward the appropriate parts to those. It doesn't mean everybody needs it. Typically, the people I'm talking to are probably not the ones who need a heck of a lot of it. But I digress. There are tutors. There are a couple of tutors available for anatomy and physiology, and it may be a valuable resource, particularly for people who are having considerable difficulty. Most of the time, they talk about peer tutors. So these are junior, senior students who have done adequately well in this, perhaps in other courses. So something to take advantage of if you just have certain concepts you want to clarify. I'll send you the information. The choice is yours. No one can compel you to do this. If you don't like doing that, that's fine too. And I'm always available for questions and concerns. So I did want to establish that for the record. I was not sure that they had. It depends on the students who have the are able to do it academically and are available to do it with regard, because they're what they're doing career wise. Okay, enough of that stuff. On with the knee. It's a knee. You got to get there. First, largest and most complex joint of the body. It's got a little bit of everything. You have ligaments on the inside, which are separate and almost distinctive synovial structures, joint or joint-like structures within the joint itself. You have cartilage, we talked about, like with the temporomandibular joint. You've got extra pieces of cartilage, that's a complicating factor. You have a somewhat unique capsule, and you have lateral ligaments. One's kind of part of the assembly and one's not. And all of that structural, plus all the complexity of the additional structures around it, make this a real difficult joint to deal with. When there's so many things going on, and rather than being just one joint, okay, like we talked about the saddle joint at the base of your thumb, one joint, two bones, no other stuff in there other than the shape of the bones. Okay, here you've got other things that are involved with it. You have fat pads, you have bursal sacs, you have additional soft tissue structures. A lot of stuff's going on in the knee. And you have three distinct joints that are there. You have the simpler one is the femoropatellar joint. So really what the patella is a fulcrum, functionally speaking. It allows you to extend your foot forcefully, like kicking a ball. It gives you a lot of strength when you have to utilize it, depending on the activities, and a substantial amount of support. Think of it that way. It really has nothing to do with the tibia. The only thing it has to do with the tibia is the patellar ligament happens to attach there. But the bone itself is the fulcrum. It's only got cartilage facing the femur, and it only deals with the femur. And all it does is it rides with the femur. When you bend it, it rides down to the inferior part of the femur. When you extend it, okay, it rides up to the anterior part of the femur. That's all it's gliding along in there, hence the gliding and sliding joint. It can be a problem if it goes out of position. That usually is a mechanical problem with your legs or your feet, or maybe your hips. Most of us could do without the patella if we had to. It wouldn't be that desirable, but it wouldn't probably affect most of your jobs. So bad fall, trauma, if somebody fractures a patella, unless they're a serious athlete, professional athlete, collegiate athlete, then you don't start extracting patellae for any good reason. So you get the idea. It's very, very useful and it's important, but it's the least significant part of the joint, unless there's something going wrong with it. Which brings us to the joint. Your tibiofemoral joints, there effectively are two, medial and lateral, and you have different problems, particularly with the medial, and more so than you do with the lateral. It's much more effective because of the anatomical structure, relates to the complexity of the problem and the injuries that it is likely to have. Okay, so they call them tibiofemoral joints, and the most interesting thing, you all had that. You saw that beautiful round bottom of the femoral condyles. You saw that flat top of the tibia. How's that going to work? Okay? How is that going to give stability, and flexion, and extension? It can't. So we have within that joint formed two fibrocartilaginous discs that act like gaskets. And they take that flat surface. Remember what a condylar joint is. It's round, it's convex on one side, and it's concave. Those discs take that flat surface and effectively create the concavity in it. So not only does it flex and extend, it has the capacity to rotate internally when your knee bends, and then it straightens out, it rotates back externally. So that's, it moves in two axes, that's its classification scientifically speaking. Okay, lateral and medial joints together, tibial and femoral, the condyles, lateral medial menisci, singular is meniscus. So, that's the important name is meniscus, but when everybody else talks about their knee cartilage, okay, and they're not talking about the hyaline cartilage, this is different. This is fibrocartilage, they're different. Okay, and all the stuff it does. It's a good view to give you some hints. One, it hints you as to all the extra stuff. You have a bursal sac here. You don't have to know any of these names. You have a bursal sac here. You have a bursal sac here. They're always there. You have extra fat pad there. You have a lot of additional structures whose role is to provide additional support, protection, lubrication, whatever way you want to describe it. They are basically complementary to the overall function of the joint. There's so much stuff, there's so many moving parts, you need a lot of areas that can protect and buffer it. That's where the bursal sacs and the fat pads kind of come in. You can see the discs, they're wider on the periphery, on the exterior, and as they move centrally or toward the interior, they flatten out. And that's what's going to effectively, when you look at the shape, and like I think the next slide, you get an idea of how it provides that effectively a concavity that allows it to do the rotational component. And what you're going to see additionally is that we have a nice thick capsule in the back. The back of the knee is remarkably stable. Anytime you get in these sort of natural body cavities, the axilla, the cubital fossa, and the popliteal fossa, the back of your knee, all sorts of business going on. Blood vessels, nerves, all traversing that area. There's a lot of, when I say a lot of business, there's a lot of structures going on. It's a very complicated area anatomically. It's complicated for anybody to understand anatomically, so you have all of those structures, and that's where there's a substantial amount of coverage with muscles and tendons and things like that. The interior part of the knee is mostly various types of soft tissue, and you're going to see the names associated with it called retinacula. We talked about the biceps tendon and how you could rupture a biceps, not the tendon, but it ruptures its way out of the sheath. Well, what's holding the sheath against the bone is something called retinacula. It's not quite as thick as a ligament, but it's not like a little flimsy kind of a tissue, sort of in between. And that I don't think I would be asking anybody about the word retinacula, but I'm trying to give you an idea of what's going on in this place. So this is a really good view of what's going on in the interior. You can see from this, This is lateral, this is medial. The lateral meniscus is more C-shaped. This is maybe a little bit more oval. Okay, they're both attached more centrally. That are there, and you can see just from the way they've illustrated this that you can see this thicker on the outside, how it contours down. I think you can appreciate that. And then you have the sort of the flattened area. And so that's where you get the idea of creating this degree of concavity to marry to the convexity of the femoral condyles. So I might have misspoken before. It's convex and concave. This is the concave guy. It's there. What's interesting about this is you can see the complexity of the structures. They're not even showing you the collateral ligaments of the capsule, but you have these guys here. This is the anterior cruciate. This is the posterior cruciate. Cruciate because they crisscross. They're cruciform or cross-shaped. The anterior is typically thicker, and the big kicker, why we have more problems on the medial aspect, is it is adherent, basically incorporated with the meniscus. Posterior cruciate ligament does not. It may look like it's going over it, but it's not attached to either of these menisci. On top of that, the capsule, not shown, also adheres to the cartilage, and moreover, the medial collateral ligament is effectively part of the capsule. It's what's called a capsular ligament. It's just a thickening of the capsule. So you have three structures, four actually, the capsule: medial collateral ligament, capsule itself, medial meniscus, and the anterior cruciate ligament, that are all to some extent intertwined with one another. So typically, if you injure one, you frequently injure all, particularly at significant traumatic events. When we see cruciate tears in and of themselves, that is typically the non-contact injury. That's probably what happened to the Steelers' Miles Killebrew, who's a great special teams player. And they're starting to attribute to the field and things like that. As I recall, where that injury occurred, I did not see that was an area the field was chewed up. But, the Players Association will, try, they're going to try to make their case in any event. But all that aside, that's really, comparatively speaking, although very severe, a less severe injury than what you're going to see is called the triad of injuries, which involves ruptures of cruciate, tearing of the meniscus, and tearing of the medial collateral ligament. So and sometimes these occur all by themselves separately, depending on the nature of the injury, if it's a sport that's involved, the activity that's involved. Some of them don't require sport or anything like that, as you will see. So that's a really good view. When I do lab, usually that's kind of, I'll have diagrams to label or point to. That'd be one of the ones I would do. Which we will not do. Not doing it on the test. That's lab stuff to me. So the capsule anteriorly, not a lot to it, a whole lot of differing degrees of density and strength of the accumulation of soft tissue. And so big player in this is the quadriceps tendon. They tell me you have those four muscles. We're going to show you in a second. And you see these retinacula, okay, are on either side and all that, and it's well personal. Blah, blah. Here, notice. The fibular or lateral collateral ligament is not adherent to and not close to the joint. It's extracapsular, where the tibial or medial collateral ligament is right up against the bone and therefore part of the capsule. These are three of the four muscles. Quadriceps means four heads, four muscles. The rectus femoris, which is the one that is the straight, basically, and sort of the leader of the pack. Okay, the vastus lateralis and vastus medialis. They get the name vastus because they're vast, they're huge. Underneath them is the one that's really important in rehabilitation of the knee. You might have remembered it's called vastus intermedius. That's the one that inserts into the capsule itself, and because of that, why we rehabilitate knee injuries with straight leg raises with weights. They're called we talk about this in muscle. Progressive resistant exercises. We do certain exercises, and the way we increase them is not repetitions or numbers or how many times a day. We gradually increase weight. That's a strengthening exercise. Strengthen that muscle, strengthens the capsule, strengthens the joint. So I talk a little bit about in the rehab aspects which I have a pretty good degree of familiarity. You can always tell if somebody knows what they're talking about or if they're BSing. So, voila. So here's the joint itself. And what they do, yeah, side to side stability, more significant when the knee is extended. These are the ones in the back. Don't have to worry about those names. There's so much. This is the back. Look at that. A lot of stuff going on. You have the muscles that are going down your leg. Those are the gastrocnemius you probably learned about. Okay, here you have the hamstring tendons, powerful leaders you can feel behind your knee. There's a whole bunch of stuff going on back there. Plus underneath here, major blood and nerve supply to the lower extremity. It's a complex zone. So that just gives you an idea of the complexity. I'm not interested in all those names. So the intercapsular ligaments, the anterior and posterior cruciate ligaments. I don't buy it outside this. That's what strikes me. They're outside of the knee. To me, they really aren't. The knee is filled with fluid. These are just separate structures that have their own synovial fluid surrounding them. I mean, because it's that. If a student is just looking at a PowerPoint like this, that confuses them. I think it would confuse me. So here they are. And basically what happens, where side-to-side stability is collateral ligaments, major stability front to back are the cruciates. So before we had the advances in technology and could really use an MRI to identify exactly what was torn, where, how severe. And they still do this, though we don't see it because they're in a blue tent in a football field or taking them into a locker room. You would have somebody have the knee flexed as they thought they tore up a cruciate. And you'd have whoever was the examiner, head trainer, team doc, whatever, trained personnel. They pull on the tibia with the knee, somebody supporting the knee bent, pull it out. It's called the anterior drawer sign. If I push it in, it's called the posterior drawer sign. It's positive if you think of a dresser drawer. If you pull it out and it doesn't stop where it's supposed to, the next thing you know, the whole thing's coming out. So you get an idea what normal is. If it comes out too far, too quickly, anterior drawer sign positive. That means you've ruptured the anterior cruciate. If you're pushing in your drawer and all of a sudden it's going past the stop zone, posterior drawer sign, posterior drawer sign. And we even have double drawer signs for really severe. So they're nasty. The joint fills with a lot of blood and an increased amount of joint fluid. When you suck it out, it looks like it's all blood. I have an authority on that because I have a son. Did I tell you tore it up biking? Yes? No? BMX bike rider, dirt jumper, that type of stuff. Those guys you see on the X Games. Thank you. So he's like 16 when he tore up his ACL. I think he had 3 knee surgeries by the time he was 18. Did I mention not to have children? Don't have children. He continues to annoy me this day. Note to everybody here. So he just texted me. So he just got a job offer, really good one. And he goes, I got to go up. As soon as he signed the offer sheet and submitted it, they all of a sudden they said, you must go now to wherever and get the drug test. Note to everybody for jobs, be aware of that. He drives. He has a hazmat license and a TSA. He's like those big oil and tanker trucks. So depending on the field, I'm saying to you all sincerely, many of you are going into healthcare. That's a licensed field. You do not, starting right this very instant, do not want a DUI or any of that stuff. That may prohibit your ability to pass narcotics, to have DA or controlled substances. Please be aware of what I'm telling you. This is what? DUI? No. Really drink? No. I never. The last moving violation I got was my son and I, not this one, my older son, driving up clear my mom out of her attendance. She was going into nursing home full time. We're going up 79, and we're talking. I borrowed my daughter's truck. We're going to pull something behind it, and I don't even know I'm doing 82, 85. Pulled over, state cop. Yeah, I'm done. That was 2009, 2010. No, I did not. So I'm saying that to you sincerely. Don't do that. That's why the good Lord made Uber and Lyft and designated drivers. So that is all part of the service. Here you can see it. So this is what they look like. And before we had technology to be able to see that, this is what it looked like inside. So along this side and that side, okay, you can see the contouring that's there. You can see the ligaments that are there. But they're showing, and here you see they're genetic sort of, in some way, showing you adherence there and the space that's there. That's really what is an important take-home point. And what we do in surgery, the old days, then they do all this arthroscopy. So you pull this thing away. So you would just take the kneecap and this whole assembly, and we call it retracting it. You loosen it and move it away so you can see what's going on inside. But these days, all of those procedures are done arthroscopically. So you're able to do those. We started using the arthroscope when I was a resident. It was the orthopedic surgeons had just gotten one. And it wasn't anything like today's technology. Compared to what we have today is remarkable. So when many of you get an opportunity to go in an operating room and see the stuff, it is just, the degree of technology just blows you away. Very, very much so. So you can see it a little bit. You can see the discs that are here, menisci, and this is what I'm talking about. 3 different injuries that are relatively common and not necessarily the same. Unathletic and not terribly active as I am, tore my medial meniscus, very common. It's called a bucket handle tear because it's kind of like the handle you would have of a bucket or a watering can. When I was bending over it was on my hands and knees, basically on my knees, putting my kids, what I'm talking about, who's 41, in and out of the car, in and out of we had a Chevy Blazer, an old style Chevy Blazer, when they were little in car seats, and then picking up toys at the local Y where they were in playground. All of a sudden I felt ripped. There it was. And the big problem when you tear the cartilage is those little flecks of cartilage will calcify as they die, and then they become somewhat bony, and that calcified cartilage or starting to form bone becomes something that gets stuck in the joint. That's exactly what the orthopedic surgeon told me. I said, well, it hurt initially, but I can move it now. And he goes, look, sooner or later, something's going to get there and lock up the joint. And you could be anywhere doing anything, and all of a sudden, you won't be able to flex your knee or straighten it out. It'll just stop where it is. So that's what, I had the procedure done, and again, back in the old days, that we did. So what we see, this triad or 3 injuries, typically come when the knee is extended and doesn't have anywhere to go. We're not, particularly if it's on the ground, okay? So you don't have, in the air, you don't see these quite as frequently. So when it's non-weight bearing or there's no contact, then this is the one that you see with certain athletes, like the one I was telling you about with the Steelers game, not last night, but on last week, on Sunday last, when all of a sudden you could see, because they were concerned about the field. Again, I don't think it was the field. Most likely that's what he suffered. The treatment in rehab is a little bit faster. It's not severe, but it's more easily overcome than that. And there's nothing new under the sun here. The first time I heard about this triad of injuries, I was a resident, and our lead orthopedic surgeon said, this guy, an orthopedic surgeon out in Oklahoma, because Oklahoma had very, very big successful college football programs, talked about the triad of injuries back in the 50s. And he said, go read that book. Okay, that he wrote a book about that. And this is where it was. So you sever, or not severs, or tear, a better term, the tibial or medial collateral ligament. You often see MCL, which is an acceptable abbreviation, the medial meniscus, and the anterior cruciate. That's the bad knee injuries like that. Now you're looking at maybe a year of rehab. So cartilage, again, like I was describing, pushing down on it, shearing it, like kneeling, moving side to side, being on your hands and knees. And this is the problem with the fragments I was talking about. I had arthroscopic surgery, and what they do, it looks kind of like this. This is a very good view to show you what actually a physician can see. And if you have something like this, they'll give you pictures. They're more than happy to give you digital pictures. You'll send you files of them these days, whatever it is. And all they do is an arthroscope, if you did not know, it's a flexible tube that you're looking through. There's a side probe that comes in, and it has like a tiny burr, like a head that you would use like a Dremel drill and a woodworking tool. And you have that in, and you're going to start shaving that down and basically burring it. You have fluid coming in from a port, keeping the knee swollen, and you have fluid going out. So you have ingress and egress. And basically, you're just shaving these things, tiny fragments, and you're flushing them out and collecting them. And then once that's done and you've remodeled it, you let it stay there, and basically it'll be covered by something called scar cartilage. And this can be done multiple times. But every time you have an injury like that, that's an additive effect. Famous football player, was a commentator on a number of Fox and other networks, named Mark Schlereth. He's probably 55, 69. I think he was a son playing professionally. He had 21 knee surgeries, offensive lineman. He won 3 Super Bowls, 1 with Washington and 2 with Denver. So, I mean, it's just fix it up. Here we go. Mostly this. And yeah, if he has not had them, he certainly will have bilateral knee replacements. That ends that. Okay, the last part is sprains and strains. A strain is not an injury. A strain is the stressor. So when you strain something, you don't really strain something. To some degree, you sprain it. The strain is the force that's involved. If you want to be technical, and you should, I'm not going to try to trip you up like that. Okay, but somebody's going to try to trip you up. So, I mean, if strains can cause serious knee injuries, true. Strains are serious knee injuries, it's false, because it's not by nature an injury. Okay? Words matter. Test taking, that's why I'm such a pain in the rear end. It's okay, I know you thought I was going to say something else. So we typically grade them first, second, and third degree. That's a matter of degree is correct. The first, sort of mild, moderate, and severe. The first is probably microscopic, painful, goes away a couple of days, maybe a week or two. Second degree, you're probably in that 3 to 6 weeks. Those typically do not require any significant treatment other than immobilization if needed. And you can start, immobilize them for a period of time, they calm down, and you start to rehabilitate them. And then, taping them, bracing them, and things like that. The third degree, the severe one, now you're looking at possibly have to do surgery, reconstruct them. Usually that's the implication. So if you're wondering what they start talking about those, okay, so say a grade 3 ankle sprain, that's probably something's going to miss a fair amount of time. Or if your doctor tells you that you have that, you might be looking at something they have to go inside and reconstruct. I tell everybody this, the generic treatment for these, okay, is to understand that the initial treatment is basically the same. If you injure yourself or somebody, somebody at home, basically you'll know pretty much if it doesn't resolve right away. If it's something, I better go take it to the emergency room or urgent care to get it looked at. But at home, if it's just, just my ankle is hurting a little bit, the acronym is price, pain, rest, ice, compression, I'll get to that in a second, elevation. Pain medicines, anti-inflammatories. Be careful. They always must be taken with food or milk. Food if you're lactose intolerant or a milk allergy. If we use almond milk a lot. It's got to coat the stomach. All of those things, aspirin, ibuprofen, Aleve, all of those damage your lining in your stomach. All, period. Be aware of that. And if somebody asks you for advice, tell them the same advice. That can be big trouble. And there's limitations on how much you can take. Tylenol does not do that, but you can take too much Tylenol if you did not know. That's the pain nugget. Rest, ice, 24 to 48 hours ice, and then the compression. Say this now for future reference. If you see somebody, if you're training with our professional staff, nursing, physical therapy, occupation, whatever they're doing, and they start doing that figure of 8 thing with the ace wrap, do me a favor. Don't tell them Dr. Stein said you're doing something criminal almost. It's the biggest weapon we have. People have no idea to put one of those things on. They're designed to be wrapped like a tube. Well, they do it on the football game different. Professional athletes are getting paid a whole lot of money, millions of dollars. The purpose for that is get them in there and play. They realize there can be problems. They'll shoot them up with pain medicine. They'll shoot them up with steroids. They'll shoot them up with local anesthesia. You go play. Different. But for everybody else, that's a weapon. With an older person or a person with bad circulation, they can lose a leg or an arm because of that. There's a right way and a wrong. But don't say, well, Dr. Stein said, it's enough that you'll know and I know. Just don't do it. I'll be happy to show you the right way to do it if you have some clinical opportunity. Happy to. Okay. Enough for that sermon. I'm sure you're done with me with that. That covers this. Luxation's complete, subluxation's partial. The arthritis nugget. Arthritis is I always call it a garbage term because it's not specific. Inflammation could be a bursa. Inflammation could be the tendon sheath, not the tendon. Tendon's a rope. Okay, periostitis, periosteum. Capsulitis, the capsule. Okay, there's a whole lot of structures that can get inflamed. Okay, so when we talk about arthritis, you need to be specific. In general, arthritis falls into 2 types, inflammatory and non-inflammatory. I know they're both sore and you both treat them similarly with the aforementioned anti-inflammatories or with steroids or with some other kind of medicine. So inflammation is, in this case, is a symptom or a sign. The reality is a true inflammatory arthritis, like rheumatoid arthritis, which would be the most common and certainly the poster child for this, is directly caused by your immune system. These are autoimmune phenomena. We do the immune system nugget in AP2. It's fascinating. I have a variant of an autoimmune disease, probably brought on by my receiving immunotherapy when they were treating my bladder cancer. Okay, because sometimes there's complications. Nobody's fault, just happened. So your immune system is monstrously important and very difficult to control. It's got a mind of its own. So, and a lot of other things can cause it to go wacky or haywire. But autoimmune diseases is your body attacking itself. For the time being, go with that. So there's lots of different types. So there's the major categories are inflammatory, not as common, degenerative, very common. The typical arthritis that grandma has, that grandpa has, that I have. Okay, the reason I'm going to my chiropractor at 4:30 this afternoon is wear and tear type of arthritis called osteoarthritis. Don't worry about everybody. If you live long enough, you're going to get it. Vast majority. I'm saying it jokingly, but it's true. I'd be happy that you're living long enough to complain about it. It's a good thing. So all of those, pain, stiffness, swelling. We won't get to talk about bacteria today. We'll talk about that on Monday. One we're going to talk about, really important disease to know about because it's the most common vector, meaning something else brings it to you. Another species, in this case a tick, and the name of that disease you probably should already know is Lyme disease. Okay. And the other one, gout, is a metabolic disease. having to do with a chemical, we won't get to that, that we produce in our body as a waste product, we can't get rid of. So we will comment those. Osteoarthritis. Most common, I'll get to what I wrote up there on the board. Most common, irreversible. Not getting any better. So you can manage it. There's treatable, but this is not reversible. It's only going to get worse, so you have to treat it appropriately. Typically, unlike ice and elevation, the golden rule is still the same as heat and exercise. Wear and tear, good way to describe it. Is it enzymes? Who knows? Broken down faster? Is it mostly hereditary? Is it occupational? Certainly, with regard to sport, if you injure it in sport, there's a very good chance that you're going to have post-traumatic arthritis 10, 20, 30 years later. There's no clock on it. Sometimes it's different, sometimes it's not. I mean, I'm not terribly physically active. You don't have a lot of trauma when you're riding around in a golf cart. Okay? So that knee doesn't bug me too much. So what happens is the cartilage breaks down, it really morphs into bone and gets trapped. And so by age 85, half of Americans, more, and all of these, arthritis favors, which just like osteoporosis, women more common than men. You'll hear it. It's usually part of normal aging. That's what I mean. You can hear it or feel it in the joint. Get your hands on it, almost feel it rubbing, and you almost sense it. And there's different things you can use. Heat, exercise, judicious use of pain relievers. This is not something you use the strong stuff on. And does anybody know what capsaicin is? So for those that do not, capsaicin is an extract of red peppers, typically hot red peppers. Peppers, the hot parts in the seeds and in the membrane when you cut it open inside. Well, peppers that we use are called capsicums. That's their family name from a plant identification or terminology. So what happens is capsaicins, we extract them, let's say from Tabasco peppers or whatever, cayenne peppers, and you rub it on. So it's not something internally, it's topical. It's been around for a long time. I used to write prescriptions for it. We can get it without a prescription now. To me, it always worked by the third rule. A third of the people, it helps. It depletes something we're going to learn about down the road called substance P, which induces pain. And additionally, massaging it seems to help sort of not allow that substance to trigger pain impulses. So it's covering the pain. It's not taking away the damage. About a third of the people it does nothing for, and a third of people, my wife, can't even tolerate it. Because it feels, even if it doesn't look like they're burning their skin, it feels like it's burning. So I mean, they have a really untoward reaction to it. And that was the same. I use it for diabetic neuropathy extensively. This is another one I call BS on. Okay, it's not. I think they're very useful. Not everybody's helped by them. It helped me, glucosamine, chondroitin sulfate. We both take it at home frequently. I just got a 40-pound bag of dog food that hurt my back yesterday at Costco. And what's in there for older dogs, weight control dogs? Glucosamine and chondroitin. Okay, so there's a lot of good supplements. This is almost like a statement, well, supplements don't really work. Yes, I think they do. My opinion, they don't work for everybody. But fortunately, by and large, if you know what you're doing, you can keep away from being harmed by them. Rheumatoid arthritis, chronic inflammatory autoimmune, body attacking itself. 2nd through 5th decades, 15 through 55. And once again, 3 out of 4, in my practice, 4 out of 5 women. You can start as early as teen years and manifest itself all the way into middle age or later middle age. And you have the same, I'll go over what I wrote on the board with regard to pain, swelling. It's systemic, so it affects blood count. It does lead to osteoporosis and all these other things that are associated with it. Last part isn't so critical. So, for osteoarthritis, large joints, asymmetrical. It's typically one side, but they don't occur at the same time. may eventually affect both knees, but it might start with one knee. So knees, ankles, hips, shoulders, elbows. Okay. So it's not, it doesn't follow like what we call bilateral and symmetrical pattern. The joint, initially what happens, it starts to narrow. As time goes on, it widens side to side. You lose the joint space. The thickness has to do with bone density. And eventually that'll just stop moving. So the big issues with this, thickening with regard to increasing bone density, eventually it narrows and becomes distorted side to side. So the first time we see is narrowing of the joints. For rheumatoid arthritis, it's an inflammatory from your, and what happens, what your white blood cells do, they cause a distinct immune reaction, and that means swelling. So it causes the joint initially to widen due to swelling. All that fluid lowers the bone density, it becomes osteoporotic. And effectively, as it's widened, it becomes unstable. This is too stable. This doesn't move this way. This instability allows it to begin to either partially or totally dislocate small joints, bilateral and symmetrical, which stand both sides. Those wonderful intertarsal, intercarpal joints, metatarsal phalangeal joints. The difference here is that the membrane itself becomes inflamed. And so while it's attacking, you get a lot of inflammatory white blood cells that release chemicals. That begins to be destructive, and the residue that they leave adheres to the cartilage and destroys it. And almost like a scar tissue on it. I mean, it's a different process. Rheumatoid bones are you can almost crush them. I mean, you have to be so careful if you're working on them surgically that they could almost fall apart in your hands, where typical osteoarthritic bones are much more common. Very often rock hard. Sometimes they're soft, but very often rock hard. And it doesn't preclude the two, they aren't mutually exclusive. Somebody could be a real mess and have both. Just good. I'm sorry, it's just the way it works. So rheumatoid arthritis, same kind of treatment, steroidal, more likely to use steroidal agents in this, non-steroidals. We have a modern field of biologicals. For the one I had, you see it advertised on TV. Initially, they gave me something called Cosentyx, which is something that blocks an inflammatory agent that you learn about, hopefully, in immune system. And then subsequently, they changed me to Humira, and that's something that blocks this tumor necrosis factor. I had to inject myself every 2 weeks with an agent like that. I didn't particularly like the way it made me feel. And about a year ago, I just said, I'm done with this stuff. So I stopped using it. I take a couple of leave every morning, try to go to the gym more than once in a while, try to eat relatively sensibly when my wife doesn't bring home all sorts of goodies. Don't even start. It's not her fault. I have no willpower. And so understand, I have not only experience as a treating physician, but as someone who suffers with it. This is classic. Called ulnar drift. They dislocate weight when it swells and become unstable, and your tendons pull to the side. Same with your feet. They drift fibularly to the outside. So it's really, I mean, I can't tell you how many people you see like this. It's not just bone and joint. People die from rheumatoid arthritis. I didn't get a chance to tell you about this. Remember I asked about activities of daily living? Basically, the way this chart works, right here, that's a dividing line. This is good, this is bad. What it means is, and that's a normal distribution, about 10% of people get diagnosed with something like rheumatoid, and it's just a diagnosis. They meet the criteria physician diagnosed. That's the only way you would know they have it. It absolutely doesn't impact them. On the other hand, 40%, guys, 40% people have the diagnosis, and it doesn't limit their ability to work. They have it, they have medicine, maybe there's some limitations and things things they can do. But they basically, just the same as you and I, maybe with some constraints about the type of jobs they get, the type of activities, recreation, etc. And maybe some of the medicines have some issues. You can live with either one of these. The bad side, half these people, 40% of them, this is the ADLs. What it does is they're unable to do activities of daily living. This is true for all of these autoimmune diseases. Systemic lupus erythematosus, psoriatic arthritis. You'll learn about those. They're more common than you think. So, if you can't do activities of daily living, these are people, difficult time in the workplace. I mean, there's varying degree. They're not all confined to home. But maybe they need help. Maybe these people to come in periodically to assist them, bathing, shower, whatever. Get the idea? And there's 10% human life. Seen a case like that in the other classes. Case of a young girl who was in her 20s, so stricken by rheumatoid arthritis that she went from literally being normal, being in bed in a fetal position, barely talking, and just constant pain. And in 6 months, and within another 6 months, she was surely, as her doctor told us, not be there. Acutely, we saw when we were students. We were at Moss Rehabilitation Institute in Philadelphia, doing as a students, we were touring with a rheumatologist. It's hard. And I'll leave you with that to understand that these are very severe. Thank you very much. We'll conclude a little bit of arthritis and begin muscle physiology in earnest on Monday. Have a good weekend. Happy Friday to all. Oh, we'll try. We'll try.